Thank you very much for that kind introduction. I'd forgotten that ties don't exist in Israel. Just the 3 people in the room wearing them are in the front row here, so maybe we shall abandon them later on. Yeah, it's good to be back. This is my 4th trip to Israel. My first was just after the Six-Day War, and Daphne Gladman was a bright young thing. Still is a bright young thing, I might say, but it's always a pleasure to come and visit Israel. And I think whoever designed this logo did a great job. I think it sums up what we're doing between rheumatologists and dermatologists. You've got the 2 specialties depicted by the stethoscope, meeting in the middle, working together. You've got a pelvic-shaped image with sacroiliac joints. It's almost perfect. I say almost perfect because it probably needed that adding just to say that we're talking grappa here. So whoever designed it, you have my admiration, because as Philip Mead says, I like doing acronyms and things like this, putting them together for these meetings and organizations. So we're a little bit behind time. I'll probably speed up a little bit. This is what I'm going to talk about for screening tools. I'm going to talk about them finally, but just a little bit of preamble about so-called pre-disease and biomarkers in psoriasis for psoriatic arthritis. Now, Dr. Gizondi is getting lots of mentions today. This is some of his early work, where he performed ultrasound examination on the entheses of the lower limb in people with psoriasis and people with other skin disorders. And these people didn't have any musculoskeletal complaints. They're asymptomatic. And what was found here, as you can see, on the left here, these are the Guess score, which is a score of thickening and abnormality at the entheses of the lower limb. Was higher in the group with psoriasis to those with alternative skin disease. And this has been confirmed by a number of other studies and in a number of other disorders, such as inflammatory bowel disease. But we're not yet gone to the next step to determine what significance these abnormalities have. They may indicate people who are going to go on and develop psoriatic arthritis. Remember, they didn't have any symptoms at the time these scans were done, or they may not, and we're still working on that subject. If they do identify people who are going to go on and develop arthritis, then perhaps we should be treating them at this stage when they haven't got symptoms to try and prevent the disease developing. And in a way, we're handicapped in psoriatic arthritis by our legacy of rheumatoid arthritis, whereby it's good to get the patient early and treat them aggressively, like a cancer, if you like, to get them into remission and keep them in remission. We don't yet know whether that paradigm fits for psoriatic arthritis, but we're working on it, and that will appear, that information will appear as time moves on. So that's just summarizing what I've been saying. We don't know how ubiquitous these asymptomatic abnormalities are, whether they occur in the upper limb as well. We do know that if you take a group of people and stratify them by age, the older you are, the more likely you are to have abnormalities such as that I've just shown. So any study like this has got to be carefully done and balanced and matched, age, sex, and matched for these abnormalities. So the biomarker story is really also poorly developed at the present time. GRAPPA's hoping to set up a biomarker study in the near future. There are a number of putative candidates that you might be able to look at in people with psoriasis and predict who's going to develop the arthritis. But as yet, and here are some possible candidates. We've already heard about osteoclast precursors. But there are other candidates in the pot, as it were: cross-lapse, osteocalcin, serum interleukin-2 receptor, and osteoprotegin that could be potential biomarkers. Of course, the biggest biomarker we've got as rheumatologists for psoriatic arthritis is psoriasis. It's an obvious and very convincing biomarker. We know that there are genetic and environmental risk factors for people in the population to develop psoriasis, and there are emerging genetic and environmental factors for those with psoriasis who develop PSA. But it's this group that we know up to a third are going to develop psoriatic arthritis where we should be targeting our screening efforts. And if you look at people with psoriasis, there are skin-related factors that predict the onset or development of psoriatic arthritis. And these three are listed here from the paper by Wilson 4 years ago. Nail disease is a predictor, as is scalp and natal cleft psoriasis. Interestingly, you probably know your rheumatologists are not keen on getting clothes off patients. In fact, rheumatology patients on the whole are not keen on getting undressed, in my experience. And there are many reasons for that. In England, it's too cold and damp most of the time. But, of course, we never see, unless we go looking for it, this natal cleft psoriasis. And if we don't go delving into the scalp, we don't see that. And the nail disease may also be missed. So these indicators are often missed by rheumatologists. Environmental risk factors, well, this is from Daphne's longitudinal cohort. Infection, lifting, as it were, trauma, that might be a risk factor for development of arthritis. And in Daphne's series, smoking appeared to be protective against the development of it, but although there are some controversial data about that from other series. And as I say, up to a third, I mean, people quote the 40% figure here, but this is a bit outdated, I think. It looks like if you take a sample of people in secondary care, hospital clinics, about up to a third will have psoriatic arthritis, but not all of them will be recognised. But if you look at the whole spectrum in the community, then it's probably about 11, 12, 13%. It's about 1 in 6. So there's quite a lot of psoriatic arthritis out there. And as I say, it's not all recognised. In the study we did here in the UK, of these 14%, half of them were out there unrecognised in the community. They'd seen their doctors, they'd even been diagnosed with arthritis, but not psoriatic arthritis. And some of them had had disease for up to 15 years. So there is a lot of it about, and it's unrecognised. So the concept of a screening tool that would ease the way and help identify those who've got psoriatic arthritis was introduced. And the first one was developed in Canada way back in 1997 by Paul Peloso, and it took a while for people to get onto that and modify it. But since then, there have been a number of these tools released, as you can see. The modified pack, the PAYS, the Topaz, the PEST, the PASC, more recently the ERP. And I'm going to concentrate a little bit on the PAYS, the Topaz, and the PEST, which seem to be the three major instruments that are used for screening. And they're all a little bit different. They perform different roles. The PAYS was probably the first of these. This was developed in Boston by a dermatologist and rheumatologist. It was designed to assess the type of arthritis and the impact of it as well. This is Abrar Qureshi in Boston. And this is the PAYS. So there are a series of questions about symptoms up here, which the patient responds by agreeing or disagreeing. So questions like, I feel tired, my joints hurt, my back hurts, and so on. And whatever number they indicate, they're all added up to give a final score down here at the end of the day. So these questions are symptoms, and these questions relate to the impact of those symptoms. In a way, it's not a homogeneous questionnaire because it does mix the two symptoms and function. But Abrar Qureshi and colleagues have translated it into many languages. There's a certain amount of commercial use of it. So it's obviously well used and respected within the dermatology world. In Toronto, it was developed the Toronto Psoriatic Arthritis Screening Tool, which was designed again by a dermatologist and rheumatologist. It includes pictures of psoriasis, and it was really, this is the purpose of this questionnaire is to screen in the general population. So the PAs and the PES, which you're going to see, are for use in people who've already diagnosed with psoriasis. This is for the general population. So in that, there are pictures here which are of elbow psoriasis and nail psoriasis, and questions that include joint symptoms, back symptoms, and dactylitis. Now, the Leeds questionnaire was developed out of that community survey I told you about. So we had a whole raft of questions given to patients, and then we performed logistic regression on these. And the 5 highest scoring questions, if you like, were put together as the Leeds questionnaire. And again, these are similar questions. Have you ever had a joint that's been swollen? Has a doctor ever told you you've got arthritis? Do your fingernails have pits? Have you had pain in the heel? Or have you had a finger that was completely swollen and painful for no apparent reason? And there's a mannequin as well, but that's not used in the scoring. That's just so that you can refer to the joints that are painful. So which of these tools is best? Which should we use? Which is easiest to use? Well, there's no doubt the PEST is quickest to complete because there are only 5 questions in the mannequin, but none of them take long to complete. You're talking a question minutes, and since patients wait to see you in the waiting room, they can be filling any of these out while waiting. We've just finished a study that compared the 3 in a head-to-head study. So we compared the PAs, the TOPAZ, and the PEST. This was done in secondary care dermatology clinics in the UK. So all patients who didn't already have a diagnosis of psoriatic arthritis were given the 3 questionnaires in a pack. Questionnaires were randomized, so they weren't all getting them in the same order. And all the positive responders were asked to come back for a full examination by a rheumatologist. And our sample size estimate was 200 to compare the sensitivity and specificities that we knew from the developmental phase. And in fact, as you'll see down here, that we had recruited 195 examined patients, so we're just slightly short of our target sample size. To get that number, we had to give out almost 1,000 questionnaires. So you lose quite a lot along the way to get them in for examination. And we used the CASPER criteria for diagnosis, and 47 of those 195 had psoriatic arthritis not previously diagnosed. So how did the questionnaires perform in comparison? Well, you see here I've listed the sensitivity and specificity of each of the questionnaires, TOPAZ, PAS, and PEST. And at the bottom here, the area under the curve of the receiver operating curve, which is a measure of discriminative ability. So you have to have an area above 0.5 to be discriminatory. And this, the figures here reflect how these 3 questionnaires performed in this head-to-head study. You'll note that the sensitivities are reasonably acceptable, but the specificities are pretty poor compared to what was found in the developmental phase of each of these questionnaires. But the design of the study was liable to overestimate sensitivity and underestimate specificity because we only examined positive responders. Nevertheless, the specificities that were so low here were due to the fact that these questionnaires were picking up non-psoriatic arthritis, osteoarthritis in particular, fibromyalgia and such things. And this was always the worry with screening questionnaires, that you'd give them out to your patients, say on an annual basis, you'll get the positive responders and you send them to your rheumatology colleagues, and we'd be flooded with all these people who didn't have psoriatic arthritis. So this is a worry, and I'll show you how we're working on improving that in a minute. In fact, although those areas looked different, statistically there was no difference between the 3 questionnaires. And as I say, we were picking up a lot of other rheumatological diagnoses. The other thing that we noticed in that study was that although some of the questionnaires, particularly the TOPAZ, has questions about back pain, we were not picking up axial disease as well as we should do. And one of the problems we have is this, is that psoriatic arthritis is a very heterogeneous disease. We've already heard about that from Philip Meese, but Moll and Wright described these 5 subgroups: symmetrical polyarthritis, arthritis mutilans, axial disease, oligoarthritis, and distal interphalangeal predominant. What they didn't put in their subgrouping was the dactylitic group, which you see in up to 40%, and the enthesitic group. Enthesitis is found in up to 50% of our patients at any one time. So to design a tool that's going to cover the whole spectrum of the disease is not going to be easy. And that's one of the problems with these screening tools. However, what was interesting with the contest study was the more positive responses you got. In other words, if you answered all 3 of the tools in a positive way, you were much more likely to have psoriatic arthritis than answering only 1 or 2. And that suggested to us that within the 3 questionnaires somewhere were key questions that were more likely to detect psoriatic arthritis compared to other diseases. So we put all the questionnaires together, reran the statistical analysis, and developed a new questionnaire that we've called the contest questionnaire. And this table here describes the results of that study, which has just been accepted in arthritis care and research. And I've listed here the TOPAZ pays. I should say, first of all, that this data that these were compared on, this contest questionnaire, was a combination of data from the contest study, a study done in Dublin of a similar design, and a study done in Salt Lake City of a similar design. So it was a much bigger database. And we compared the PACE, the PEST, and the TOPAZ again, but also compared the contest, which was picking out those key questions. We had a weighted version of the contest as well, which I won't go into, and a contest that relied only on joint counts, and one that relied on a cart analysis. And you can see that on the whole, the contest in terms of area under the curve does perform better than the 3 developmental questionnaires, the PEST, the PACE, and the TOPAZ. But even at 0.74, there's still room for improvement, because there's your confidence intervals, which are still quite wide. So I don't think we're quite there yet in terms of screening tools and getting the best tool. But so at the moment, I think you have to choose the one you like, that you think is simplest, and perhaps administer that on an annual basis to your patients as they're coming to see you and waiting in clinic. And I think that is an important role that dermatologists in this audience have got. However, there are dermatologists, and this is a paper, was from Steve Feldman's group. This is a quotation some time ago that he thought dermatologists should play a much more pivotal role in identifying psoriatic arthritis and, in fact, treating psoriatic arthritis. And this is just to remind us that what we use to classify psoriatic arthritis from other forms of arthritis are the Caspar criteria. They are classification criteria, but they've also been used successfully as diagnostic criteria. And you will see that to classify psoriatic arthritis, it's mandatory to have inflammatory articular disease of the joints, the entheses, or the spine. I'll come back to that in a minute, but if you can accept that that is the entry criterion, then with having current psoriasis and just one of these features, you can classify or be diagnosed with psoriatic arthritis. If there's a personal or family history and 2 of the features, or indeed in the absence of psoriasis and 3 of the following features, the same can apply. Now, the problem here is not, from a dermatology point of view, not psoriasis, that's your job. It's not nail disease, that's your job. A negative test for rheumatoid factor is the lab's job. A radiological evidence for new bone formation is the radiologist's job. But the problem that faces you is the dactylitis, identifying that, and identifying this stem, the inflammatory articular disease. Daphne, some years ago, set up a study in Toronto to look at this, and a group of dermatologists and rheumatologists met to examine 20 patients, 10 of whom 20 patients had psoriasis and psoriatic arthritis. So the 10 rheumatologists examined the skin and the joints, the 10 dermatologists examined the skin and the joints. And the results are, for the joints side of things, are published here. And these figures are the intra-class correlation coefficients. So they are measures of agreement rather than accuracy of identification. So if we look at tender joint counts, then overall, dermatologists and rheumatologists agreed on the tender joint count. Rheumatologists were a little more in agreement than dermatologists, but those figures are pretty good and there was no difference between them statistically. When it comes to swollen joint count, then the agreement was a lot less, but it was equally bad for rheumatologists and dermatologists. So dermatologists are still holding their heads high at this point. Dactylitis, it was bad overall, but rheumatologists weren't too bad in agreeing that whether a joint, a finger or toe was dactylitic. Dermatologists didn't agree at all. So the question of agreeing on whether a joint or a digit is dactylitic is one that will probably need improvement. And don't forget, these dermatologists were experts in this field, so had a lot of experience. The physician global assessment, not very good, again, across the spectrum. So I think you can feel fairly pleased with yourself about the tender and swollen joint count, but unless you get too smug, look at these figures for the skin. Now, the same rules apply here. This is the dermatologists and rheumatologists looking at skin, and here's the body surface area figures. Rheumatologists much more in agreement than dermatologists about body surface area. Here's the PASI, pretty good across the board, I think, really. And look at the figures for the modified NAPSI, also good, which is surprising to me, because doing a NAPSI and counting the pits, to me, it's difficult to do. And again, the physician global assessment, rheumatologists did pretty well compared to dermatologists. So I think what this study tells us is that we can assess each other's domains, as it were. We are physicians. We shouldn't concentrate on our own specialty in particular. And I think there's room for improvement. And I have some sympathy and agreement with Steve Feldman, who says that I should be looking at the skin. I should be looking more carefully than I do, so I should be getting the patient's clothes off. And you should perhaps be looking at the joints, particularly if a patient comes in with a screening questionnaire that scores positive. You should be thinking now, exactly why is that? And is this psoriatic arthritis? Is there any point in you doing that? Does it help the patient if you're picking them up earlier? Well, as I said, we're living with the rheumatoid arthritis paradigm, but there is some evidence, and that some of it's at the back of the room there, the Ticopa study, treat to target in early disease, that you get better outcomes the earlier you treat. So I think the evidence is beginning to emerge that it is true that we should be finding these patients and treating them more aggressively. And that's the reason. This is, again, Daphne's data from Toronto, that well over 2/3 of our patients do get progressive disease. There's that small group with the mutilans, but 2/3 have this slowly progressive polyarticular disease. So just in conclusion then, many of your and our patients with psoriasis do have psoriatic arthritis, and about half of them don't know it because they've not been diagnosed yet. And if we could find an easy way to pick those patients up, then I think we should use it. And I think screening tools are an easy way to get the ball rolling. They're in development. They'll be getting more refined. And I think as time goes on, we will have better tools. But no test is perfect. And that's true of all tests. So combining one of the screening tools with a simple physical examination, and remember that STEM for CASPAR, we're working on trying to get key historical and clinical features that will help rheumatologists and dermatologists pick that up. Then combining that with this tool, I think, will make a big difference moving forward. So thank you for your attention. I'd be happy to answer any questions.